When we've got a patient with a diarrhea, we have to answer for three questions. Where should we treat patient? Should we make additional lab test or some lab test? And how should we treat this patient? First of all, we have to decide when patient needs a hospitalization. So we have to use this clinical science, and we use it in Russia. First of all, we have to hospitalize children with severe form of the disease. We have to hospitalize patients with the mild and moderate forms, but in case of severe abdominal pain, to consult patient with the surgeons, and sometimes they need just monitoring of the condition. Patient with concomitant infection disease, for example, otitis media or pneumonia. Patient from the special institute, like orphanage, board school, etc., regardless of severity of the disease. Patient from the large or social disadvantaged families, as well as young children with unfavorable premorbid background, for example, malnutrition or severe in other diseases. The absence of the positive dynamics, some ineffectiveness of our treatment, and increasing the severity of the disease during first 2-3 days from the diarrhea beginning. And of course, we need the hospitalized patient in the urgent scheme when we've got the complication like a malignant fever, like a seizures, like a neurotoxic syndrome, hypovolemic shock, etc. So, what's our European colleagues recommend for doctors to, in case of the treatment localization? First of all, we have to recommend the hospitalization for young babies younger than 2 months, babies with children with severe underlying disease, such as in Russian recommendation, patient with a persistent vomiting, patient with severe diarrhea, and patient with some signs reported by the parents, signs of dehydration. What's about the neurotoxic syndrome? Neurotoxic syndrome, we use this term in Russia, and this syndrome includes some cerebral symptoms such as meningeal symptoms, severe vomiting and seizures, headache, and redness for convulsions. When we can provoke the seizures, and some general symptoms like persistent hypothermia, malignant fever, tachycardia and impaired blood pressure, hypertension. We can see both conditions in this situation. We can see the rigid heart rhythm without any changes due to physical exercises, due to physical activity, not exercises, of course, in this patient, and due to the temperature. It's not correlate with the temperature grade. Internal organ innervation disturbances such as a cardiovascular system, like a respiratory system, and finally we can see the multi-system organ failure. The hyperventilation syndrome we can diagnose in patient with a severe dyspnea, with a severe dyspnea more than 80 per minute, and patient looks like an animal at bay. We can see the shallow breathing, and we can see the some cyanosis, paleness, and its increase in the time, and development of toxic hypoxia, interstitial pneumonia, pulmonary edema, pneumonic edema. And criteria for diagnosing of neurogenic tachycardia syndrome coronary insufficiency. It's very rare condition in pediatric patients. Only in severe toxication or very severe dehydration we can see this in patients with diarrhea. But what can we see? We can see the very severe malignant tachycardia in combination with pronounced anxiety, pallor and cyanosis, skin cyanosis, swelling and pulsation of the jugular veins, and granting breath. Granting the breath and swelling of the veins of the nose. We can see this in patients with this syndrome. So all these syndromes, meaning syndromes, needs the urgent hospitalization. And of course the hypovolemic shock. As all the shock we can see the low, extremely low blood pressure, just drop in blood pressure. We can see the hypoxic signs like a cyanosis, hypothermia, cold extremities, and of course we will see the central nervous affection, which can realize by convulsions, some mental impairment, and possible respiratory arrest. And septic, infectious, toxic shock. We will see the growing signs of vascular insufficiency, and we can see some pallor of skin, marble signs of skin, a grayish color. We can see the hypostasis spots and some increased capillary refill time. We can see the severe tachycardia, some problems with auscultation, deafness of heart sounds. We can see the, again, drop in blood pressure. We can see the mental disorders like a stupor or coma. It's a multiply organ failure and very dangerous if you can see the adrenal insufficiency, acute adrenal insufficiency. The appearance signs of hemorrhagic syndrome like a petechial rash, bleeding, nasal bleeding, first of all intestinal bleeding, and we can see some changes in body temperature. And it's very dangerous if you will see the patient with a similar condition and the hypothermia. It's very severe ill child and needs immediate resuscitation. And of course, because it's hypovolemic, in some cases hypovolemic shock, we can see the dehydration signs. If we will see the prognostic factors which can lead to bad and poor prognosis, we will see in these factors the malnutrition, zinc deficiency, persistent diarrhea before this disease, and immunosuppression. And in which situation we will see these conditions. Poor social economical status for malnutrition, deficiencies, multiple deficiencies, macronutrient, micronutrient deficiencies, poor nutritional status due to some severe chronic disease. Sometimes we can see it, for example, in patients with congenital heart diseases. Zinc deficiency, we will see in patient in the developing countries, and zinc deficiency will lead to prolonged diarrhea and increasing frequency of diarrhea and increasing inflammation of bowels. Persistent diarrhea, it leads, of course, malnutrition and weight loss and immunosuppression as well. And immunosuppression, which can appear due to HIV, first of all, due to hereditary immunodeficiencies, and due to all the chronic infectional condition, of course, will prolong the time of the diarrhea and severeness of these symptoms. We discuss our indication for hospitalization in Russia, what we can see in other guidelines. In American guidelines, what are the red flag symptoms which needs the patient to be hospitalized? It's altered sensorium, billows or bloody vomiting, cyanosis, it's inconsolable crying, of excessive irritability. It's some rash, particular rash, and we've seen it, yes, before we discuss it. It's rapid breathing, it's a toxic appearance, it's a poor peripheral perfusion, increasing the capillary refill time, and young age. But you see, it's younger than 6 months. In European countries, recommendation, immediate hospitalization will do for patient with shock, severe dehydration, neurological abnormalities like seizures, lethargy. This is presence of the bilious in vomiting and some profuse vomiting. It's some ineffectiveness of the treatment, for example, for oral rehydration. If we suspect the surgical infection, you see like in Russian recommendation, and conditions for a safe follow-up and home management are not met. So we discuss the family problems. So you see in all the guidelines, we can see quite similar recommendations for hospitalization. And we are talked about the complications, and we are talking about the most common complication in the viral infection. And you remember that viral infection is the most common cause of disease in diarrheal disease in patients younger than 5 years. So the most dangerous things in for patient with watery diarrhea, for the viral diarrhea, it's a dehydration. And we've got the different scale which can help us to evaluate the severity of dehydration. The most, not most suitable, the easiest one is the clinical dehydration score, CDS, for children younger than 3 years. And you can see only 4 signs, 4 criteria: general appearance, eyes condition, mucous membrane, and tears. And we've got the score of 0, 1, or 2 balls, and summarizing of these balls will give us the some points to severity, to decide what is the severity of the dehydration of many patients. So from 1 to 4, it's a mild to moderate dehydration, 5 to 8, severe dehydration. In Russia, we prefer to use our national scale, but it's based on the Gorelick scale. For dehydration, we've got the analog in the Western countries, and Gorelick scale includes all the signs which we can see in CDS, and additionally, we can see some criteria like capillary refill time, and we remember that it should be prolonged more than 2 seconds. We can see the status of mucous membranes. It may be moist or dry. We can see the breathing, breath rate, and heart rate. We can see the skin elasticity, and you can see capillary refill time and skin elasticity. We can measure it, so it will be very helpful for us. And additionally, urine output. So it's more suitable for using in the medical society. What about the additional laboratory findings? I will not show you the Russian recommendation because we've got a lot of laboratory tests, and in some of them we can't explain what for. In most non-severe cases, which you will see as a general practitioners, we can recommend as our colleagues from the United States of America or the European Union, we have to see maybe bicarbonate concentration or electrolyte concentration, but in patients who are in hospitals. And of course, we will check it in patients who need the IV therapy and who undergo the IV therapy. So, of course, we will check the electrolyte status, we will see the glucose level, we will see the bicarbonate as the acidosis marker. So, in all the recommendation, they are not recommend to do the stool test in all the patients in routine cases, only in patients with suspected septicemia, with the blood and mucus of the stool, and in patients who got some immunodeficiency or severe chronic disease. Maybe you will do the stool examination for patients who just returned and who just arrived from the countries with some specific intestinal infection to find this infection. Differential diagnosis. Sometimes we've got some symptoms which can be in diarrhea and which can be in other diseases. So it may be central nervous system infection in case of altered mental status. It may be bowel obstructions in case of the bilious vomiting. It may be inflammatory bowel disease in case of the blood and mucus sample in the stool. Dyspnea are common thing in pneumonia, fever in all the infection, localized abdominal pain needs to exclude the surgical pathology, neck stiffness or bulging fontanelle. It's quite rare in patients with diarrhea, but it's common for meningitis and non-blanching rash toxic shock syndrome. It's not differential diagnosis, it's, for my opinion, it's some checking for the complication of the bacterial diarrhea. So, but we have to remember about antibiotics. We have to check it in patient history because antibiotic use can lead to antibiotic-associated diarrhea. So, how can we treat patient with infectional diarrhea? It includes some three components in which we can see the absorbance and probiotics using, rehydration and diet, and etiological treatment, but we have to discuss it, and all the researchers still discuss these questions. First of all, we have to remember about hygiene and isolation precautions in case of hospitalization, and just routine things like isolation, like using gloves, like hand hygiene, and other. So diet. We have to start feed patient as soon as possible when we stop, when we finish, and we will do another regimen of the oral rehydration, because it can help the brush border cells to digest the food and to produce the enzymes. And finally, it will help with absorption and decrease the complication like malnutrition. Breastfeeding should be continued in all the cases, and in case of mild gastroenteritis, mild dehydration, we have recommended mothers to use the breastfeeding as some part of the oral rehydration. So it should be as frequent as patient wants, and maybe a little bit more frequent. If we start to do this again after 2-4 hours with the oral rehydration therapy. For patients who use formula feeding, we recommend to decrease the time interval and decrease, of course, the volume of one meal, and to do it more frequent. The number of the meal during the day may be 10 times in a small volume. So we prescribe this formula feeding. The discussion about which formula should we use still continue in all the countries. In Russia, we recommend the low lactose formula and all lactose free for couple of days, not for all the time. And when we will start to use the standard formula, of course, we use it with supplements, lactase supplements. For patients who've got the solid food diet, we have to recommend excluding the whole milk dairy products, porridge. We have to recommend to decrease or exclude some vegetables and fruits with higher fibers volume, such as pears, plums, grapes, and some grapes. It's because a lot of carbohydrates inside, some sugars, and that is why, and some fruitic acids like in citrus fruits. We have to exclude the fatty meats and carbonated drinks. But I know that in some countries, doctors recommend to use a cola as an oral rehydration solution. The World Health Organization recommend to use it in case we have no another solution for the oral rehydration. If you've got the choice between the nothing and cola, of course we will use a cola for rehydration because patient needs the water. But be aware about the carbohydrates consumption and the enzyme deficiency can lead the increase diarrhea in case of osmotic diarrhea. The broad diet has no enough evidence-based result of the research, but as you know, in your countries, probably in Russia, we traditionally use boiled rice and dried bread toast for patients' diet. We didn't use a banana and apples before, but now parents start to use it, and we have no some a negative effect of this diet. So you can recommend it and you can say yes if parents will ask you about this diet. So rehydration is the most important part of treatment patient with diarrhea. Oral rehydration is a preferable way of rehydration. If patient able to drink, if patient able to keep this volume of fluid without vomiting, we should use the oral rehydration. It's most physiological. We will prevent the hypernatremia in this patient. We will prevent the water toxication of this patient. So we should use the oral rehydration. We can use the oral rehydration solution by just drinking, or if patient don't want to drink and has no vomiting, we can use another gastric tube. And it's quite effective and safe. Oral rehydration solution should be given slowly by the parents using a teaspoon or syringe or medicine dropper at rates of 5 ml every 1-2 minutes. You can start with maybe 5 ml every 5 minutes to see how patient can keep it. And if the patient will not demonstrate you vomiting, you can use this scheme, 5 ml every 1-2 minutes. How to calculate what the volume needs a patient? You can use the World Health Organization guidelines and you can see the patient's oral rehydration solution volumes which connect with the patient's weight and age. And you can see this scheme. I will not read it. What should you remember? You should remember that you should use a proper oral rehydration solution. And now, World Health Organization recommends the low osmolar oral rehydration solution with osmolarity 245, and in the previous combination you see the osmolarity 311, 270, 280, depends on company. Please, if you will recommend the in case you will recommend the oral rehydration for patients with osmotic diarrhea, and again, it's most common diarrhea in patients younger than 5 years, you have to recommend the reduced osmolarity. 245, 240 is the best choice. A Russian recommendation about the calculation of the oral rehydration solution volume. In the first 6 hours, we will use the volume of the liquids 40-50 ml per kg in case of the mild dehydration and 80-90 ml per kg in case of moderate to severe dehydration. Stage 1, it's the first 6 hours, so we calculate this volume and we should give it for patient for this 6 hours. And stage 2, it's stage of maintenance of the water liquid in patient body. So for all the severity of the dehydration, we will use the same volume 80 from 80 up to 100 ml per kg for 24 hours, not 24 hours, for the 16 hours, because we use the 6 hours for the first stage. And we should check the effectiveness using the evaluation of the fluid loss, reducing rate of the weight loss, so we should measure the weight. We can see the disappearance of the clinical signs of dehydration, like dryness of mucous membrane, dryness of skin, a low skin turgor, capillary refill time, increased capillary refill time. We should check the urine output, and of course we have to evaluate the patient general condition, and the improvement of this means that patient have got a proper oral rehydration regime. What's our European colleagues recommend us to rehydration? If case of minimal or absent of dehydration, no immediate treatment required. If child have got a breastfeeding, we have to increase the frequency of breastfeeding. And if patient have got some solid food, we have to add some solid food or fluids like water, soup, rice water, or another drinks. What's usually traditional this patient family use. We have to remember that we need the 50 ml per day for children younger than 2 years this water, these fluids, and 1 liter per day for children aged to 10 years. More than 10 years old patient needs 2 liters a day. In addition, if you've got some fluid loss with the watery stool and the vomiting, we should add 10 ml per kg of body weight additional for each stool and 2 ml per kg for each episode of vomiting. Mild to moderate dehydration needs 50-100 ml per kg ORS during 2 to 4 hours period, and this period depends of age. If patient younger, we have to use a more slow rate. And Again, we have to remember 10 ml per kg for each stool episode and 2 ml per kg for each vomiting episode. Severe dehydration. Severe dehydration in most cases needs intravenous fluid infusion, and we will prescribe it in patients with inability for drink, profuse vomiting, of course for patients with shock, impaired mental status, in patients with ineffective oral rehydration, for patients with severe acidosis and severe abdominal distension or ileus. IV rehydration due to European recommendation. They use the isotonic crystalloid solution, 0.9% saline or lactated ringer solution, 2 ml per kg bolus. So just one time. And then we have to check the blood pressure. It's patient with shock. So if we've got the same low blood pressure, we have second or third bolus at the same dose after the 10 to 15 minutes. And if we will see no improvement, we have to see another cause of shock. Isotonic solution is preferable. In some rare cases, you will need to use a ringer lactate solution. Glucose may be added to saline solution once. It should be used on the second stage, not on the first stage of rehydration. American recommendation. You see, we've got the little bit increased volume of the bolus, 30 ml per kg, and then 70 ml in 5 hours. So we've got the two stage. First stage, it's a 30 ml, and second stage, maintenance. The next very important component of the treatment patient with infectional diarrhea, it's absorbents. Traditionally in Russian Federation we use a lot of absorbents, and you can see in this picture, but only one preparation, diosmectide, recommended by the European Society of Gastroenterologists, pediatric gastroenterologists, hepatologists, nutritiologists. It's diosmectide, and we usually use it during 1 week. And the indication for stopping of this therapy usually is the normalization of the stool frequency and stool volume. Next part is the probiotics. Probiotics are recommended by the European recommendation guidelines and some guidelines from the American Association. For example, American Association of Pediatrics recommends the probiotics to this group of patients. So the recommended strains is Lactobacillus GG, Lactobacillus rhamnosus, Saccharomyces boulardii, and Lactobacillus reuteri. It should be the exact strains to show the maximal effectiveness. Antiemetics. Antiemetics recommend both American and European guidelines, and ondansetron only one preparation which we can use in pediatric patient from weight 8 kilos. But you have to be aware about the border effect, the QT interval prolongation, so it can lead to very severe arrhythmias and cardiac arrest. So you have to be very careful with taking anamnesis to sort the information about the presence prolonged QT syndrome or about the family members with this syndrome, because it's most cases it's a family disease. Zinc supplementation. Zinc supplementation we usually use in territories, in areas with zinc deficiency. Patient needs a zinc preparation in dosage 10 milligrams in case of the children younger than 6 months, and 20 milligrams in case of children older than 6 months. And the duration of the therapy is usually 2 weeks. And the last component of the therapy you see with some questions, because all the researchers and doctors still discuss about necessity of the etiologic therapy. And first of all, we will discuss the necessity of the antibiotics using. In one hand, if we will have a proper prescription of antibiotics, if we've got the bacterial diarrhea, of course we will see the just immediate improvement of the patient condition using the antibiotics. And this is very good, and this argument help and leads the doctor's decision. Doctors made the decision to use the antibiotics. But on the other hand, we will see first of all the high risk of the antibiotic association diarrhea appearance. We have to remember about dramatically growth of the antibiotic resistance in all the countries. And other thing, if we will start to use the antibiotics in patients with the escherichiosis, sugar toxin producing Escherichia coli, in this case, we will see the severe complication. One of the severest complications, hemolytic uremic syndrome. And if we will prescribe the antibiotics for patients with the viral diarrhea, we will see the increasing duration of the disease. The Russian Federation used the recommendation in which we use the antibiotics in case of the bacterial diarrhea, inflammatory type of diarrhea with blood mucus in the stool, and additionally, we will see in patients severe underlying condition, comorbid pathology, for example, severe diseases of the nervous system, like a cerebral palsy, maybe severe congenital disease, and other. We will use it in patients with immunodeficiency and multisystemal bacterial complication, like septic diseases, and of course in children younger than 1 year. What antibiotics usually are suitable for these purposes? It depends on the bacteria. If you got the shigellosis, the first line antibiotics due to European recommendation, it's azithromycin. In Russia, we traditionally use the amoxicillin and the combination of amoxicillin and clavulanate, and the second line therapy, the cephalosporins. You see the same recommendation. The second line therapy is cefixime, but the first line is macrolides. In case of salmonellosis, the first line is cephalosporins, ceftriaxone, and the second azithromycin. In case of Campylobacter infection, which can be in patient younger than 1 year, we will see the first line, and for young children it's only one antibiotic, because the second line antibiotic doxycycline is contraindicated in patient younger than 8 years. In case of the escherichiosis, which appear due to Escherichia coli toxin producing Escherichia coli infection, antibiotics are contraindicated. Absolutely, 100% contraindicated. In other cases of escherichiosis, again, azithromycin as cefixime as the first line and second line therapy indicated for this patient. In case of cholera, again, we will start with azithromycin, and in patients older than 8 years, as a second line therapy, we can use the doxycycline. Clostridium difficile. Clostridium difficile is an infectional agent who leads the antibiotic association diarrhea. In this case, we will use a metronidazole or vancomycin treatment. In case of parasites or helminths invasion, we will use for parasites metronidazole, and for the helminths it's albendazole, mebendazole or tinidazole using for treatment of this patient. So the treatment of patient with the diarrhea, the patient younger than 5 years, based on the proper rehydration and in some cases with the etiology therapy, only in some cases. Russian recommendation includes the antiviral preparation, immunoactivators, immunostimulators, but we have no enough proper research results. So before we will have it, we can't recommend it for patient with the diarrhea, the pediatric patient with the diarrhea. And you can see this recommendation. I put this table without translation. If somebody will interest in this treatment, you can read here and you can translate it by yourself. So you can see that all the recommendation. Complication in patient with infection with diarrheal disease, it's chronicity of this process, it's malnutrition in case of osmotic diarrhea, it's hemolytic uremic syndrome. We discussed a little bit earlier about it. Of course, it's a dehydration, and in some cases, severe situation like a renal failure, like a toxic ileus, like a septic shock. Thank you for attention. Bye.